Hi everyone, welcome to today's episode of Face Facts by Dr Yusra. On today's episode, I have Mr. Ahmed, who is our weight loss prescriber at the clinic and a specialist in mental health, director of pharmacy at a NHS trust. And today we've talked about GLP-1 as a medication. Some of you will know this as Ozempic. We've talked about Ozempic. We've talked about Mounjaro, we've talked about Wegovy, the safety, the criteria, the side effect profile, how to know if you're getting counterfeit or fraudulent medication, what you need to know before having Ozempic, and all of the health benefits that you might find from this medication. I hope you enjoyed this episode. Welcome on today's podcast.
Thanks.
So for today, I have the amazing, very talented, very educated, very knowledgeable Mr. Mohammed Ahmed.
Right.
I call you Mo, but I'm going to try and call you Mr. Ahmed for today's
That's
podcast. So Mo, introduce yourself. Tell us a little bit about your background.
Sure. So currently I'm a Deputy Director of Pharmacy for an acute trust. But prior to that, I was a mental health specialist pharmacist for about 7 years. Mm-hmm. So really kind of getting to understand the mental health aspects of patient care. And I've got a real passion and interest in health and fitness, well-being. So I was quite an early adopter, understander of the GLP-1 medications that we're going to talk about today, but really kind of having that holistic approach, bringing in the mental health aspects and providing more of a lifestyle function as opposed to a medical intervention in that sense.
Mm-hmm. And you teach medical professionals.
Yeah, so as part of that, because we were quite early on the scene with the medications, we've set up, me and my business partner, a company to teach medical professionals about the use of GLP-1s, the appropriate use, and providing more of a holistic service, looking at lifestyle factors and them being a component and not just the sole intervention that we use. So that's something that we offer out as well to any healthcare professional.
And every time I sit with you and have a discussion, it kind of goes through a rabbit hole. You're a source of so much knowledge, and I have a huge amount of respect for you. And for those of you who don't know, Mr. Ahmed is available at the clinic, and you see our patients and you look after them on their journey back to health, on their weight loss journeys, and also hair loss. But today in particular, we're talking about weight loss, and we're talking about Ozempic, which is a prescription-only medication.
That's right.
So this is not for advertising, this is for knowledge. On this podcast, I really like to break down facts, present my patients and my colleagues with all of the facts out there. Because I think there's a lot of good and bad press around Ozempic, a lot of confusion.
Yeah.
There's also some newer drugs on the market, Mounjaro, Wegovy, which we do offer. But I want to break it down. I want to talk about the actual medication and what the difference is between the different ones that are available. So talk to me about GLP-1. What is that?
Right, yeah. So let's start with GLP-1.
Let's start with the basics.
So GLP-1 stands for glucagon-like peptide 1. Without getting too fancy, it's basically a hormone that your body produces naturally. So this is part of kind of your gut function. When we have something to eat, a whole cascade of hormones and transmitters are released through the gut, and that's part of your body's regulation of appetite and gut function. So GLP-1 is one of them. So when we have something to eat, basically there's a trigger of release of GLP-1 throughout the stomach, and then that kind of moves to the brain and moves to other parts of the bodies and has different functions. And then within about, say, 20 minutes of having something to eat, the body will then shut down production, and then it'll be very quickly eliminated. So the function that it has, the one that we're mostly interested in, is that it affects the brain and it affects your feelings of satiety. So how full you feel. So if you think about when you have something to eat, we want to feel fuller. We want our appetite to reduce. And that's what this compound does. It triggers us to feel full, and it triggers us to kind of start to switch off our appetite as part of that meal. Other functions it has as well is to do with the digestion. So if we think once food is in the stomach, we slow down that gastric emptying, so your body's got time to break it down. Then we get an increased release of insulin to help shuttle away all the nutrients into the muscles, into the fat cells. And we also dampen down the release of glucagon. So if you're not sure, glucagon is kind of the counteract to insulin. So glucagon releases the energy, insulin stores the energy. So if you think of it, it's all a very logical process that we want to happen when we have something to eat. And then, as I say, after that food's gone into the stomach, eventually that will be switched off. So what's happened now is we've got GLP-1, drug companies have took it, seen what it does, and now have tweaked it slightly so that instead of being only available during that meal time, it's now available throughout. So you would have a GLP-1 agonist, which is basically a medication that is similar to the GLP-1 that your body produces, with a slight tweak. That means it's a lot harder for your body to break down, and that will last for a week at a time, or a day at a time, depending on what injection that we end up using. So if you think we've got almost that constant switch to say, I feel fuller, I'm not as hungry, everything, your gut kind of slows down its good transit time, which means all that put together, people tend to eat less, they feel less hungry, they crave less foods, and that's predominantly how these medications work. That's kind of the main mode of action. And then it does get a bit more complicated with the newer drugs like Monjoro and how they work as well.
So before we get to that, I want to really fully break down the understanding of GLP-1. So GLP-1 is a peptide.
That's right.
Is it a hormone?
It's a peptide hormone. So it's sort of what they call it, an incretin. So these neurotransmitters, peptides, hormones that are released during the normal gut function. So it is a type of
hormone, so to speak. So I find the body incredible. The more I learn about it, the more I am fascinated by the divine design. And what I've also, you might know, but my background is I had, apart from my dental surgery background, not my professional background, my personal background is I had an autoimmune condition at the age of 19. And that's when I started to really break down my understanding of the human body more than what was taught in my undergraduate degree, like really look at lifestyle factors, because I feel like medicine, dentistry, pharmacy, a lot of these undergraduate medical caring professional degrees are focused on diagnosis of disease and treatment of disease. So recognizing symptoms of disease and then looking at the treatments of those diseases according to a set protocol. And what I love about you, and obviously why you work at the clinic, is because we share that ethos of holistic care. And that means empowering our patients to understand their body and their power in terms of lifestyle modification. But we're going to do another podcast about food, I think, because I think it's really important to understand that weight gain, being overweight, or obesity is actually a huge issue globally, worldwide. It's massive. Something like 60 to 70% of the adult population in the United Kingdom are overweight. And we can't put that down to willpower alone. There's a lot more going on there.
It's more complicated.
It's much more complicated. And I think GLP-1 is really interesting because it's being used as a method or a mode of treatment to treat patients who are overweight or obese, or those who are approaching type 2 diabetes. And so if we break it down, understanding that every part of our body talks to each other is I think really fascinating, really important, because one of the things I think, again, about traditional medicine or modern medicine is that often doctors, and I'm not dissing any doctors, that's the background that I come from, but so often we become hyper specialized in certain areas that we don't take a bird's eye view and look at what else is going on and the root cause of disease. And when you start to understand that, then you can put the pieces together. And when it comes to weight loss, weight gain, food, the impact of food, another thing that I think is really interesting is that the gut talks to the brain. And even GLP-1 as this hormone, it's not just working on our stomach alone, it talks to our brain.
Absolutely.
And the process of eating is regulated by hormones, ghrelin and leptin, which I'd love you to talk about a little bit more. I always think of ghrelin like this little gremlin that makes us hungry. And when our ghrelin is high, we want food. We get hungry, we start to eat. And once we've eaten and food comes into our body, a lot of people only think insulin is secreted to take that sugar and put it, to get it out of our bloodstream. GLP-1 is interesting because it talks to our brain and it tells our brain, actually, we're starting to get this food in. And you get the hormone leptin, which tells us we're full. So you get this feeling of satiety. And then you get you stop eating. But that takes time. Yeah. It's not instant. And so sometimes we overconsume food in that process.
Oh, definitely.
So the interesting thing about GLP-1 is that feeling of satiety, and this can be good and this can be bad, and the reduced gastric motility or gastric emptying can be good or bad. anything in excess can obviously be negative. But talk to me about ghrelin and leptin. How does that work? What's the interplay there?
Yeah, so they're kind of like your higher level control. If you think about, you mentioned obviously GLP-1, there's actually quite a lot more different peptides that are involved, but your kind of higher level would be your leptin and your ghrelin. So your leptin is sort of your fullness type. It's released by the fat cells. So as fat cells start to deplete, they reduce the amount of leptin being secreted, which then increases the hunger, and the ghrelin. And your ghrelin is kind of counteracting in the sense of your ghrelin would start to increase in between meals. So it's at its lowest at a meal time when you've had something to eat, and it'll gradually build up. But there are some factors to do with like your circadian rhythm and what your routine you have around eating and your meal times, where your ghrelin will spike around those meal times because you're expecting the food to come in. So there's some kind of lifestyle aspect to it, not just kind of that autonomous ongoing background secretion. But what they found is with leptin, which is quite interesting, that it's not so much the presence of leptin that switches off your appetite. It's that having not enough leptin really triggers the appetite. But then there's a certain level where your body will develop like a leptin resistance. So if you think why do people gain weight? Because if the leptin was there, then they would not feel as hungry and stop eating. But what happens in obesity is the leptin levels are so high all the time that you develop a leptin resistance, and then it doesn't have the same effects on the weight and the weight management. And we think about, why do people regain weight after coming off a diet? It's because of that deficit in leptin and reduction really ramps up their appetite. But then once they're back to kind of that normal level, the appetite tends to switch off a bit.
So hold on a second. So leptin is the hormone that makes us feel full, right? And when we have enlarged fat cells, our leptin kind of goes quiet a little bit, right?
It's still there, but
it's
you
less.
don't listen to it as much.
But at the same time, when you have, I call it an inflamed fat cell, because with fat, and I've said this before in a podcast, God didn't give you fat to punish you. Fat is actually there for a reason, and it's there for thermoregulation, hormonal balance, and hormonal regulation. But because of, I think, a lot of issues is because of ultra-processed food, but that's another podcast. Because eating can really be seen as an autonomous process in that, breathing, we don't think about breathing. Food is important fuel for function. And if you're eating things that breathe or live, natural whole foods, actually your body regulates itself in terms of when it's full and when to eat much better than all the other nonsensical, non-food-like substances found in ultra-processed foods. But like I say, podcast for later. So I think we have confused our brains and our bodies because of current diet.
Massively.
Such that we no longer can regulate properly our food intake, right? And so when we have this inflamed fat cell, an enlarged fat cell, really what should happen is your leptin should be high, you should feel full, and you don't want to eat as much. But actually you develop leptin resistance, right? And I wonder if that's hand in hand with insulin resistance, you can tell me. But this is an issue that we see a lot, is that when patients lose weight, I don't know if it's psychological, and we know that it's hormonal as well, but I think it's a dual approach or process, where psychologically they go, I lost weight, so I can actually afford to have that cheat meal. But also their leptin goes up. The leptin goes down and the ghrelin goes up. So they've lost weight and suddenly they're much hungrier. And so that's why they struggle. So this weight loss, weight gain cycle is notorious.
Oh, it's 90% of diets fail, not because people fail to lose the weight, because they can't keep the weight off. That's a real struggle. And that's why it's all about lifestyle intervention. Because if you don't change why you were overweight in the first place and what led you to that, and you go back to those habits, you will end up with the same result. And the way we provide the service is really focusing in on that. The medication is available online and people will take it, but like any other weight loss intervention, like ketogenic diet, whatever you want to do, you do it for that time, you lose weight, but then it's what happens afterwards. And that's what we try and use, is the medication as an opportunity to then work on the lifestyle factors to kind of set that new habits, new food selection, and then keep the weight off on the long term. Because like you said, your body's amazing at regulating itself, regulates the blood pressure, immune system, and your body listens to the environment, but we've got a broken environment now that's really triggered that accelerated weight gain. And it's, like you said, it's not about willpower. It's about how do we manage the environment? How do we think smartly, not internally, but also externally, like what's around us? Who do we live with? How does our work affect it? How does our activity levels affect it? And putting things in place that then means that we can keep the weight off on the long term. And that's what we really try and build with our clients.
I have to say credit to you, because our patients are all, we've not suffered or struggled with patients gaining back the weight. And I think it's because of that particular part of it. Certainly I've seen patients who have procured Ozempic or other medication online under no supervision. They lose weight. They develop all of the complexities and the issues and the side effects, including Ozempic face. And today you've told me about Ozempic bum, and we can talk about that. And then they put the weight back on. And actually they've done themselves a disservice because they've suffered that, they've reduced muscle mass, they've reduced body mass, facial fat pads. And they're back to square one in terms of their unhealthy lifestyle.
Yeah.
So, okay, so we understand about leptin and ghrelin and the interplay of these hormones with each other, and all of our body is kind of antagonistic. There's a pull and a push. So is leptin resistance in line with insulin resistance? Does it go kind of hand in hand?
Yeah, similar in the sense of it's to do with an overabundance, over-secretion, which your body's not designed to really handle. So if you think about insulin resistance, there's a constant supply of insulin, constant on switch for your glucose transport to be pulling in that glucose into your muscles, into your liver, and eventually they get tired, those receptors, they don't respond as well. Because naturally what should happen is we have ebbs and flows, where we would have something to eat, you get a spike in insulin, but then you do some physical activity which counteracts and gives you the glucagon, and it gives that off time to occur. But when you've got that constant on switch, you develop the resistance, and then things don't function as well as they should. And then we get to this kind of arms race where we have to use medications to really bump up the amount of insulin we've got in our bodies to then counteract that resistance. And it just becomes a vicious cycle. But I mean, some of the consequences then of the insulin resistance is the development of diabetes, the hyperglycemia, but also the visceral fat as well. Because now that your fat cells are resistant to the insulin, they can't draw in the excess energy. So then that just gets deposited throughout your body around your organs, and that's the dangerous fat, and that's what we need to be mindful of. So it's
the visceral fat. I want to labor on this a little bit. I think there's still a slight misunderstanding or confusion around visceral fat and subcutaneous fat. So subcutaneous fat is that soft, pinchable fat, often found more in women than in men. And visceral fat is the fat that lines the organs, which is the dangerous fat, right? But it's also the fat that's most amenable to loss via diet and exercise. Subcutaneous fat can be a little bit more stubborn. So there are two different types. Now, visceral fat is an indication or a precursor for disease. And the visceral fat is basically the fat around the abdomen. And there is I think if your waistline is more than 104 centimeters, then that is one of the signs for us that this patient may be at risk of developing diabetes. We call it pre-diabetic. Because it indicates that there is this excess storage of fat. And actually, it's probably a lifestyle. You're seeing it now when you're 40, but actually this started in your childhood when your routine was eating a lot, even if it's little but often, or having unhealthy foods. And so you have this constant sugar attack, which, from a dental perspective is bad for your teeth, but from a body perspective results in this hormonal cascade. So you're eating, your body takes that sugar, you get this insulin spike. And if that is happening all day, every day, eventually the receptors to insulin go, actually, this is a bit too much for me.
Yeah.
So they start to switch off and almost like the boy who cried wolf, they just stop responding. And then you have this insulin resistance that we speak about. And then you don't have the normal fat regulation. So you get excess fat being stored in these fat cells. So visceral fat is something that people need to understand is not an aesthetic issue, or not an aesthetic issue alone. It is a health issue.
Yeah.
It predisposes to a huge number of chronic disease. Can you tell us a little bit more about that?
Yeah, so I mean, the analogy I think of is, you've got an overstuffed pantry, and then you try and put more in, and it just starts to accumulate on the outside. And you think about, like you mentioned, glucose. The reason that ends up with visceral fat is your body, your liver converts the glucose into fat, into triglycerides, and then they're supposed to be stored into your subcutaneous fat, your adipose tissue, but there's nowhere for it to go, so it just gets left, and a lot of it gets left around the liver itself. And what that means is you've got high circulating levels of triglycerides, and high circulating levels of fat in your blood generally. So hyperlipidemia becomes an issue. And if you think about cardiometabolic health, so cardiovascular system is at risk. You're at risk of developing blood clots and hardening of the arteries and your blood vessels because of this excess fat around. But also in terms of diabetes, that the excess glucose itself is like sandpaper rubbing against the insides of your blood vessels. So what that does is it creates gaps for the fat to stick to, and then you get your development of plaques. So you've got a really difficult situation that puts you gradually more and more at risk of developing severe complication from your health. So it's the diabetes itself isn't what causes the problem. It's the complications of the diabetes that causes the problem. And like you said, it could be okay up until you get to your 40s and that accumulated damage starts to build. And it's like, well, we have to reverse that. We have to do something about it.
And can you reverse that?
Yeah, with the right lifestyle interventions, absolutely. And, when we talk about the medications, some of the benefits that have been shown in the studies is a reduction in visceral fat. Your body's inflammatory markers are raised as well, and that state is a very high stress state for the body, and that again puts you at more risk. So the medications plus the lifestyle factors kind of turn everything down again. So it reinvigorates your insulin sensitivity, start to draw that visceral fat away, start to manage the glucose levels, give a more consistent glucose profile. So the health benefits are quite significant. So a lot of people look at it as a weight management aesthetics type of viewpoint, but actually there's some good health consequences from it. The studies that have been done around the GLP-1 medications have shown positive health outcomes. And I think we need to remember as well, some of them have been around as a diabetes treatment for quite some time. And they've shown reduction in HbA1c, reduction in fasting glucose levels.
And cardiovascular disease.
Yeah, and cardiovascular outcomes. So reduction in blood pressure, reduced systemic inflammation. So as well as like the thing we want, we actually get these other positive effects as well.
It is, I think it's a really interesting and valuable tool in our toolkit to, not just, as you say, treat the aesthetic impacts of obesity and being overweight, but actually improve longevity and improve health. And our approach is not medicate and off you go and stick with that for life, but we use it as a kind of a boost to help our patients who are struggling. Because often it's like psychological, I just can't do it. I'm destined to this. That's it, And so it's a boost and a catalyst for them to get into action. And there's been a huge number of studies that have shown, and like you say, it's been around for a long time. It's been around for over 20 years. The first one that came out that people were using was Saxenda, and we can talk about that. Or not the first one, but the one that was being used more for weight loss. And the studies have shown a reduction in development of cardiovascular disease, but also neurological conditions like Parkinson's and dementia and Alzheimer's, which actually makes sense because when you are overweight, when you do have high levels of visceral fat, essentially what that means is that your fat cell has expanded. It's not that you've grown more fat cells. A lot of people misunderstand how that fat works. You're not growing more fat cells, that your fat cell has literally expanded like a balloon. And now it's leaking out pro-inflammatory messages because every single cell in our body talks to each other, communicates. And so these pro-inflammatory messages are putting our body into this heightened inflammatory state that you talk about, and heightened internal physiological stress, and not psychological stress, is physiological stress, exerts a negative impact on everything in your body. And so when you have, and including your gut microbiome, and it's really interesting when you look at the gut-brain axis, or even the oral microbiome and the brain axis, the microbiome, which is a natural bacterial flora that exists within us, our microbiome and that bacterial flora can exert positive health benefits. But when it's dysregulated, and one of the hallmarks of aging is dysbiosis, dysregulation of our microbiome, that happens with aging. It happens with hormonal changes like menopause and andropause, but it happens more when you are overweight or obese because you are in this state of physiological stress. And that means that your brain, if your gut microbiome is not good and is inflamed, your brain, you get neurological inflammation. This is clinically proven. It's not debatable. We know that if you have dysregulation of your oral microbiome, you're much more likely to develop Alzheimer's and dementia. So this gut-brain axis works two ways. If your brain is inflamed, your gut's inflamed. If your gut's inflamed, your brain's inflamed, and vice versa. And so we know that you're more likely to develop Parkinson's and Alzheimer's and dementia. So this is, for me, I'm really, as I'm aging, and I'm getting closer to, I'm not yet there, but I'm aging and I'm learning about longevity and about health and about frailty. I don't want to develop Alzheimer's or dementia or type 2 diabetes or cardiovascular disease. And so I'm starting to think, actually, how can I avoid that? What can I do in my lifestyle to prevent that from happening? And I think more people need to understand that when you are overweight, it isn't an aesthetic issue alone. Often patients come into my clinic and they say, I just don't like how I look, and I'm fit into my jeans as well. I'm not confident in a dress. I totally get all of that. But that's a side effect. That's the end game now, where you're uncomfortable with where you're at physically, aesthetically, but now we need to induce a physiological change in order to get that aesthetic change. Okay, so we've understood about the hormonal regulation. I want to talk about how and why we've gone from Saxenda to Ozempic to Mounjaro and Wegovy. Talk to me about that evolution.
So to start with, the GLP-1 agonists weren't marketed for weight loss at all, but part of the studies that went into the use of GLP-1 agonists in diabetes, they found that there was almost like a coincidental weight loss associated with them. So this is a spontaneous loss of weight for the patients that had the medication treatment versus those that didn't, who were on the placebo arm of the studies. So basically,
so Saxenda was, sorry to interrupt, was first given for type 2 diabetes.
Yeah, so liraglutide is the medication, and Victoza was the brand used for diabetes. So the liraglutide medication was used in trial, and you've got separate trials, but you've got basically an arm of placebo, which these are patients that don't get the drug, but they don't know they're not getting the drug. And then similar arm of patients who are getting the drug, but again, don't know that they're getting the drug. So they compared lots of different things like your glucose, HbA1c, cholesterol levels, etc. And weight was one of them. And what was found was that without telling anybody anything, those patients that took the GLP-1 agonist had a reduction in weight. So that obviously then starts to trigger, well, these medications have a weight loss implication. So then another set of studies was done with Saxenda or with liraglutide, and this was purely focusing on the weight aspect. So these aren't in patients with diabetes; these are relatively healthy patients who were overweight. And then again, you do the same thing: placebo, medication, but also some lifestyle intervention to support them in helping them to lose weight. So you've got people, both sides, being told how they can lose weight and what they can do to intervene. But the side that took the medication had a much more significant weight loss with the liraglutide. So that then set up the company to be able to use that evidence to then market the drug as a weight loss medication. So Saxenda became the weight loss medication. And if you're not sure about how regulation works in the UK for medicines, you can't utilize a medication or you can't license a drug for a particular use unless you have the evidence to support that. And that has to be, a very robust process through the regulatory bodies in the UK to be able to then say, market the drug for that use. So Saxenda was then marketable for weight loss. But it's quite an early stage medication. So whilst it was effective, you have to take it every day. So it's a daily injection. It was fairly effective, but not that potent. And then this same company then made an alternative medication called semaglutide. So semaglutide is a weekly injection versus a daily injection.
So it had a longer half-life.
A longer half-life, so less impact on the patient. But more importantly, it's a much more potent medicine. So if you think about the maximum daily dose for Saxenda was 3 milligrams a day. The maximum weekly dose for semaglutide was 1 milligram a day. And that 1 milligram was more effective than the 3 milligrams daily. So it's a very potent medication in that sense. But again, that started off as a diabetes drug. They found that, again, the weight loss occurred, placebo versus none. So then they put...
Sorry to interrupt you there, but was it a diabetes drug or a pre-diabetic drug?
So it was for diabetes itself.
Okay.
The trials have got done in patients on insulin, patients on no anti-diabetic medications, patients on different like metformin, sulfonylureas. But the evidence in all those cases was that it reduced the weight.
Okay.
So then there was another set of studies done called the STEP trials, so semaglutide treatment in obesity, and they're kind of a series of trials similar to those that they did for Saxenda, where you've got the lifestyle intervention, you've got that coaching and support to lose weight. But in these studies, they went to a higher dose, so they went to 2.4 milligrams instead of 1 milligram. And eventually they again showed really significant weight loss versus placebo. So patients over the course of a year lost about 15 kilograms using the high dose of the semaglutide versus I think only 2-ish kilograms for placebo. So that drug then became marketed as Wegovy. So Ozempic and Wegovy are the same drug. They're the same medication, but they're licensed for different things. So the Ozempic is licensed for your diabetes. The Wegovy is licensed for the weight loss, and that's to do with the studies that back up where they're used. And the doses are different because the dose you need to control your diabetes is not the same dose to get the maximum weight loss. So that's why you might see Ozempic as a 1 milligram, where Wegovy is a 2.4. But because Ozempic came out well before Wegovy did, that's where people have heard it being used. That's why it's been used more in the media. But it was used on an unlicensed basis in the sense of it wasn't marketed for weight loss. But with it being the same drug and the evidence base being there was a justification for prescribers to use it. But now that we've got Wegovy, there's no justification to now use Ozempic for weight loss because we've got this licensed version. So that's how we kind of moved from the old to the new. So these Wegovy now is 2.4 milligram, very effective medication. But now we've got a newer one on the market. So Monjoro, which is tirzepatide. So Mounjaro is a little bit different in that it's licensed both for diabetes and weight loss. So different trials, but they've kind of combined that into the one license. Now Mounjaro is different again. So you've got your kind of first generation GLP-1 agonist, which is like your liraglutide, then kind of moving on to your second generation, which is your Ozempic, semaglutide, Wegovy. And then Mounjaro is kind of like a third generation. So not only is it a GLP-1 agonist, it's a GIP-1 analog, which I mentioned before, there's more than, it's not just GLP-1, there's other incretins, peptides. So GIP is similar to GLP-1, but has a different function, but kind of works synergistically to promote weight loss. So where GIP is really interesting, so stands for glucose inhibitory polypeptide. GIP talks to your fat cells. So GIP increases how much storage occurs. So what it can do is kind of mop up visceral fat. So that kind of overspill, the GIP can pull that in. So there's been seen a reduction in visceral fat through the use of Monjoro.
So has there been a head-to-head study of Mounjaro versus Wegovy?
Not head-to-head as such yet, but the data shows, if you look at, the Wegovy trials, which is your placebo versus your semaglutide almond, your Mounjaro trials, which is your Mounjaro versus placebo, the Mounjaro appears to be more effective. So if you think about over the course of a year to maybe 14 months, people on Wegovy about 30% will lose more than 20% of the body weight. Whereas on the Mounjaro, about 60% will lose more than 20% of the body weight.
Wow.
So it's a very, even more effective medication. So in terms of my practice, I've kind of switched to using that more because of those extra benefits that we get. And part of the reason for that is, and when we talk about the side effects of the drugs, GLP-1s are kind of limited by the side effects and how they can be tolerated. So the dose you can go up to, some people can't reach the maximum dose. Whereas because Mounjaro is a GLP-1 and the GIP, the GIP aspect can counteract some of the negative effects of the GLP-1. And that's to do with like your nausea and your vomiting, feeling of sickness. And that means that you've got a higher potential dose that you could go up to. So the Mounjaro, we would start at something like 2.5 milligrams. And then over the course of weeks, gradually creep up to a maximum of 15 milligram per week. Which, I mean, you can't compare, you can't say 15 milligrams is the same as say 2.4 Wegovy, but you've got a greater ceiling to move through. But
do you need that? Do you need, is larger dose equivalent to more effective? Because one of the things, I've been in this industry for a long time, and I remember when Saxenda was first used, and we used it for our patients to help with weight loss. And the side effect profile was very high. So patients quite quickly felt nauseous. Some had vomiting. And yes, you could give them the antiemetics or the anti-nausea, anti-vomiting drugs alongside it. But then you're really ramping up what you're putting into a patient's body. And they start to feel quite uncomfortable with that. And because of the reduced gastric motility, they were also getting constipation and this constant feeling of fullness, which was uncomfortable. People still have to function and show up for work and be their best selves. So it's this balance. And now what I see being done, in my opinion, incorrectly and to the detriment of the patient is when the dose is ranked up way too quickly. And then the side effect profile, to be honest, just outweighs the benefits because they suffer rather than get all the benefits. And there's a lot of, anything. Bad news makes news. So Ozempic went wild in the press, I'd say last year, when it was being used off-label or off-license for weight loss. And obviously it was a diabetic and pre-diabetic drug to help with patients who had insulin resistance. And because it was only given once a week, they didn't have to inject themselves every day, which psychologically is easier to deal with. But also they didn't have the same kind of side effect profile. So they didn't get that nausea and that fullness and the constipation in the same way. It was kind of more controlled. And I feel that now I'm seeing a lot of patients procuring this medication from concerning sources or without proper assessment. They're taking it when they're not suitable for it. They're not a suitable candidate. Not everybody needs the drug to lose weight. And they're ranking up the dose much too quickly. Now, and I think that's what gave it the bad news, because and then everyone started using it. The Kardashians started using it. In the USA, every other person was on it. It became really, really spread like wildfire, and people thought it was this magic mushroom that they could take to solve all their life problems. And yes, we know that it helps to improve longevity and it helps to lose weight and you reduce your inflammatory markers and it helps with insulin resistance. Huge benefits, I agree. But used unsupervised has huge potential negative impacts. Not just on the constipation, the nausea and the vomiting, but too much of it, you can lose muscle mass, lean muscle mass. We're talking, and that impacts brain function. Your muscles are important for function. It's the most important, I'd argue, one of the most important tissues in your body for longevity. You need your muscles in order to move, but also the muscle mass exerts, or the muscle exerts pressure and pull on your bones, which helps with bone density. So in terms of longevity, muscle is super, super important.
Yeah.
And patients were losing 20-30%. So, we see that with Ozempic face. And when I said this to you, you laughed and you said, what's that? I've heard of Ozempic bum, but what's Ozempic face? Ozempic face is when people were losing weight much too rapidly, and they were losing the subcutaneous fat and the deep fat pads in the face, resulting in sagging tissues. So they come in looking tired, they're on a gray scale. They don't look healthy. They don't look well because they've tipped that balance. Ozempic bum, you want to tell us about Ozempic bum?
Yeah, so I think it was really important what you said about the muscle loss.
Yeah.
If you think about, your body doesn't differentiate. If you're starting to give it less sustenance, less energy, how's it going to make up that deficit? And it will use your body fat, but it will also use any muscle, because muscle is very energy intensive. So if you're not using your muscle, then your body will consider, well, why do I need to keep hold of it? It's taken me a lot to keep this muscle running, whereas fat doesn't have a high metabolic burden, whereas muscle does. So then it'll start to burn up the muscle. So what then can happen if people are very aggressive with their weight loss is they will lose the muscle, and then that leads to muscle wastage. And that kind of Ozempic bum in essence is you don't have that same development in the muscles in those areas, which obviously isn't aesthetically pleasing for some people.
So they get a flat bum.
Yeah, essentially. And what's really important for me as part of our service is that we ensure physical activity is maintained. You have to give your body a reason to hold on to the muscle. If you don't, it will lose it. And that's why physical activity, weight training, weight resistance is really, really important to make sure your body continues to utilize the muscle, continues to utilize proteins to develop it. And that goes hand in hand with the food selection aspect of it as well. And it's really important for longevity, because if you lose that muscle mass, then you're at more risk of frailty, more risk of falls. We know that fractured, like neck of femur, hip breaking your hip is a really high predictor of mortality. And this is what we want to avoid. So it's important that people kind of find that right balance and not just focus on the number on the scale, because what then can happen is we end up in a vicious cycle, because you drastically lose the weight, you lose muscle alongside of that. Then when you stop dieting, that weight comes back on, but then the muscle is not as easy to come back on as the fat and the adipose. So then it becomes that you're even a worse position than you were when you began. So when people self-medicate, there's an easy, quick result, but that doesn't mean that's the right result for you. And you've got to do it right, and you've got to follow a service that provides that holistic approach.
I think it's short-term gain, long-term loss.
Yeah, exactly.
So I have a couple of questions here, which I'm going to shoot at you, if that's okay. When we are losing weight on Ozempic or Wegovy or Mounjaro, any of these GLP-1 agonists or GIP medication, we know that the baseline metabolic rate as we age goes down. And which means that we're not able to burn fat in the way that we once did, as quickly as we once did. And you mentioned that fat and muscle has a different metabolic burden. When we are taking these medications, are we losing muscle before we're losing fat?
Not as long as you provide that reason.
Weight from a scale perspective doesn't differentiate between the body fat composition and the muscle composition.
Yeah.
So tell me about that.
So your fat stores are designed to be for long-term access. So your body would prefer to use body fat as an energy source. But if there's no reason to maintain that muscle, then it'll start to take from it. If you think about people who have surgery and have to stay in bed for even just a short amount of time, they don't walk as much, or a leg's in a cast. The muscle loss on that leg is very significant compared to the leg that they can still use. And that's in a space of, just a couple of weeks. Or astronauts coming from space back to ground, they lose a lot of muscle and they have difficulty walking because the reason to maintain that muscle mass hasn't been triggered. And that's why the lifestyle and the resistance training is so important, because you will start to lose almost maybe a 50-50 muscle and fat which might look great on the scale, but you're not going to feel your best. You're going to be more fatigued. You're not going to, when you put your clothes on, they're not going to fit in the way you want them to fit. So you need to kind of shift that balance to maybe, 80-20, because you will lose some muscle mass, but part of that as well is that your muscles hold a lot of energy. So your glucose and glycogen, so your body will glycogen, your body will break that down and utilize some of it. So that might be lost, but that muscle tissue should remain. This is just extra energy that's within the muscles, and that will refill eventually. But you want to protect your muscle tissue as much as possible. And when you buy these medications online, then they're not going to go through that with you. They're not going to give you that information, the support you need. They're going to. There's
another big issue, which is fraudulent medication. This is quite worrying, actually.
Yeah.
And we see it quite a lot with a number of different things. I mean, we know that botulinum toxin, fake botulinum toxin, otherwise known as Botox, which is a brand name, was rampant in the UK last year, where there was basically just fake stuff that resulted in patients developing abscesses and being hospitalized for 6 months. Really, really quite worrying. We see it with fillers, where fillers are being bought on eBay or unregulated pharmacies, and they're not not correctly sourced or stored. They have a high bacterial load. Patients are developing abscesses, and we're now seeing a lot of fake Ozempic, fake Wegovy, fake Mounjaro. We don't know what's in them.
Yeah.
And whilst the MHRA are trying to crack down on it, it's like the wild, wild west out there.
Oh yeah, yeah. So you need to protect yourself. There are ways that you can make sure that if you are to get the medication, it's a legitimate source. So number one is it's prescription only in the UK. So anywhere that lets you buy it without a prescription, automatically incorrect. No. You don't go for that.
Yeah.
One is always get it from the UK as well.
Yeah.
UK has very good regulation of drugs, really robust systems in place to make sure that the supply isn't counterfeit. So UK supply is really important, UK pharmacies. The next thing, if you were to purchase it online, the supplier, so if it was Lloyd's or somewhere like that offer a service, you can check that pharmacy is registered with the GPHC, which is the UK pharmacy regulator, so the General Pharmaceutical Council. So somewhere on that website should be a logo with a registration number, and you can pop that into the GPHC register and see if that's a registered pharmacy. So they're kind of your two main things to do, but also what I would say is if you want to use the medication safely, avoid places that just get you to fill in an online form and then something appears in the post. Because you'll get it, but it's not going to give you those long-term benefits, and you might have achieved some short-term result. But like we said, that long-term sacrifice. So you want something that offers a service, not just a drug.
So in terms of safety, is it a safe drug?
If used correctly, it's very safe in the sense of, if you think about other weight loss medications that can be used, can be quite dangerous. You've got cardiovascular effects. GLP-1 agonists have been around for a long time. They have a fairly good safety profile as long as they're used correctly. And like you mentioned, if people are self-medicating, they're not following the correct titration, so starting at the correct dose and gradually increasing that dose, they're going to get at risk of more side effects. And what we need to bear in mind is, because it's got a long half-life, so it's a weekly injection, once you've put that into your body, you're locked in then for a ride. You're not going to just be able to, a couple of days and it's gone.
Yeah.
It could take weeks for that medication to dissipate. So if you give yourself too high of a dose, you're going to be suffering for some time. And it's really not right. And it can have some serious consequences if used incorrectly. But when used appropriately with somebody who knows what they're doing and providing you that service, it's a fairly safe drug.
And in terms of what the weight loss journey looks like when patients are booking in at our clinic with you, what does that look like?
So I'm all about getting that history from the individual. So to start with, don't even talk about the medications. We take a really good medical history to make sure that the medication, firstly, if we were to use it, is safe and appropriate, and we're not going to have any serious complications. And then I'd like to understand kind of what that patient's journey has been to get them to the weight that they're unhappy with. So what are their lifestyle factors? Who do they live with at home? What does their job look like? what does a typical day of eating or a typical week of eating look like? What's physical activity? How is their sleep? Do they smoke? Do they drink? What's their understanding of what kind of healthy eating is? Have they tried any other diet, weight loss interventions? Are there any mental health issues that we need to consider? Previous history of eating disorders, things like that. Once we've got that picture, then we can kind of go into, well, how is the medication going to help you? The analogy I try and use is we use the medication like stabilizers on a bike. So eventually I want you to be able to ride on your own. But what we can do is manage those physiological cravings, the physiological appetite, so that we can work on the psychological. And then we use the medicine as an ability to focus in on that without being overwhelmed by feeling hungry and feeling those cravings, to the point where you can control your environment, you can control your lifestyle factors, you've put some good habits in place, and then we will gradually start to reduce. So we ramp up the dose to get to an effective dose to get the right weight loss for you, which, like you said, we don't need to go to the highest dose all the time. If, for example, you're achieving a really consistent weight loss and we're happy, there's no need for us to go higher, because higher dose might be more weight loss, but it means more side effects as well. We'll stay on that point till we get to our goal weight. And then we start to talk about, well, let's start to turn the dose back down again. Let's see how you manage your appetite coming back slowly. Let's see if these weight loss interventions we put in place have managed to regulate your appetite, because there's things we can do in terms of our food environment, etc. And then we eventually taper down. And if we need to stay for a little bit, we can do, for you to kind of reset at this lower dose of medicines, and eventually we'll kind of withdraw completely. What we don't do is ramp up the dose, you lose a ton of weight, and then we go cold turkey.
That's the worst thing.
Yeah, it's the worst thing, because then after a couple of weeks, you'll feel okay at first, but as soon as the drug wears away, the appetite just comes straight back. And then, we've undone a lot of that work. So we need to manage it carefully. And it's the same with, a lot of other medications people use for different types of interventions, like, if you're talking like antidepressants, things like that, you wouldn't just stop it. You would kind of manage that withdrawal. And again, that's why the service is important, because you're not going to get that from like just an online questionnaire and then you get the medication in the post.
I think that's another reason why there's such bad press around it, because of exactly that. People are taking a really high dose and then coming off it, and they've lost a lot of muscle mass. Their ghrelin goes up insanely, so their hormone that makes them hungry goes up, and they start eating everything in sight, and they put on even more weight than they did pre-treatment, because they were not medicated correctly. And actually, the beauty, and I think it's important, we're in the clinic, we're very holistic in our approach, and very mindful of medication. I know you're like this, because I've tried to say to you, can you treat this patient? We take on this patient. You'd be like, well, no, she doesn't fit the criteria. We can talk about criteria. It's important that we're strict in our criteria of who is a good candidate and who isn't. But the drug used correctly, the medication used correctly, and this is scientific fact, has been proven, as you said, not just to help our patients to lose weight, but actually optimize their health and well-being, improve longevity, reduce their inflammatory markers, improve neurological condition, brain function, help with regulation in their gut microbiome. So there's an overall health benefit if used correctly. And I'd like to talk about GLP-1 microdosing, because this is something that I think will become more and more used in the future. At present, there's limited data on it. And of course, we have to be data driven. But what's your thoughts on GLP microdosing, and in particular in menopausal patients? And so when I'm talking about GLP microdosing, you've talked about a daily injection, which was Saxenda, Wegovy and Ozempic, which is a weekly injection. Microdosing is the idea of giving yourself a much smaller dose a little bit more frequently, so that you're not getting a big surge of the medication and then it tailors off towards the end of the week, but actually more of a consistent smaller dose that exerts therapeutic benefit without the side effect profile.
So essentially, most medicines, all medicines, your body has a way of managing them, and some medicines will last, weeks and months. Some medicines will last a couple of hours. And drugs like Wegovy, so semaglutide and Monjoro, they've got what we call a week half-life, 1 week's half-life. So the half-life means after a week, the amount in your body will be reduced by half in those patients. So, but that isn't linear. As you said, you take the medication, there's a period of absorption. So your body will kind of start to pull that away from the injection site, start to distribute it around the body. And then we get the peak level that occurs after about 2 days or so after the injection. And then gradually over the next couple of days, it starts to come back down again. So you get sort of nothing and then a surge and then back down again. And then over time, you'll accumulate enough drug in the body that it isn't quite as significant as that, but this still does occur. And what people describe then, that is maybe the day before their injection, they can feel they're a bit more hungry, their appetite's kind of creeping back. So the kind of theory behind microdosing is you take that week's dose. So let's say it's 2.4 milligrams of Wegovy, you'll divide it by 7, and then you would give that smaller amount every day. And it, instead of having these big waves, you have like tinier waves, and then that's more of a consistent level throughout the body, so you don't get those peaks and troughs, we call them, of heightened activity, so potentially more side effects, and then these periods of lower activity, so increase in appetite. So you get that consistency, and it means more consistent results. In that case, it means more consistent management of side effects, consistent appetite management. So it's emerging. So this isn't a licensed way of using the medication in the sense of the drug manufacturer doesn't yet recommend to do it in this way. They recommend still a weekly dose. However, if there's individual discussions and the patient's really struggling with this kind of up and down cycle, it could be something we can look into for that individual and explore how we do it.
It's got to be, as with all medicine, personalized, bespoke
definitely
treatments.
In
terms of menopausal patients, we know that in the menopause, and you know, yes, I treat men, but I treat my cohort of patients are largely women from the age of 35 to 55. So perimenopause really does start at 35 because your estrogen starts to go down, your testosterone starts to go down. You might not be symptomatic until 40 or mid 40s or even late if you're lucky. But one of the main complaints is weight distribution, or fat distribution rather. And we know that pre-menopause women's body fat, the amount of abdominal fat is approximately 5% in their abdomen, whereas post-menopause is 20%. So you have this fat redistribution. And confidence and self-esteem and depression, anxiety, and a whole other, you know, bunch of symptoms. With GLP-1, I'm finding that patients who are perimenopausal are actually some of the candidates that benefit the most. What's your thoughts on that?
A lot of what occurs, I think, during that perimenopause and menopausal period is that heightened insulin resistance. So the metabolic effects, and part of that insulin resistance is also what leads to that kind of abdomen, the buildup of fat in that area, and the reduction in estrogen, like you said. So whilst it's predominantly kind of a weight loss in intervention for those patients with a higher insulin resistance, it can then become even more of a benefit and more of a synergistic response in that sense. So I was just reading there's some studies that show that patients on like HRT can benefit even more from a GLP-1 agonist in terms of weight loss and where that weight is coming from than patients who aren't yet on a HRT. And it's kind of how that then works with the hormone regulation. But a lot of the benefits really are general weight loss in itself is a positive indicator for health, and especially within menopause. But the insulin resistance is a major factor, and that's where the medications can really help with that.
In terms of who's a good candidate and who isn't,
So there's the kind of licensed indicators, and they're based on the BMI criteria. So if you're not sure what it is, your BMI is it's like an average scale of body fatness in essence. So it's taken from like a national scope of kind of the average body weights that people have versus their height, and then you kind of given a number. So there's calculators online, but basically it takes your body weight and your height, and then it spits out anywhere between 0 and 60. So for a standard healthy weight person, your BMI would be around 20 to 20 or just under 25. And that's considered kind of the healthy-ish range. And then as we start to get higher, it means you're approaching more overweightness and obesity, and then morbid obesity. Well, it's not called that anymore, but the kind of gradually heavier people. So the medication itself is licensed for use in BMI of 30 and above. So these are people who generally would look overweight, and they would describe themselves as that. And there are some caveats to it, however. So whilst it's licensed for that weight group, BMI above 30, if you've got a comorbidity, so what we mean by that is a condition as well as being overweight, that can negatively affect your health, and that comes from a certain group. So we've got like hyperlipidemia, so you've got high cholesterol levels, you've got high blood pressure, you're diabetic or type 1 or type 2, or you suffer from sleep apnea. If you have those conditions, then the target for the BMI would be lower, it'd be around 27 and a half. So you've got a lower threshold for treatment for those individuals.
And also Asian patients. There is a difference in terms of risk profile for patients who are white Caucasian and people like us who are Arab or Asian, in that we are more likely to develop cardiovascular disease or type 2 diabetes, 13 different types of cancers associated with weight gain if you are Arab or Asian descent. And therefore your criteria in terms of BMI is lower than if you were white Caucasian. Is that correct?
Yeah, and I think we need to put it into context because BMI is based on like averages, population averages.
Yeah.
You know, if you've got somebody who's like, 6 foot tall, rugby player, ripped, their BMI is going to be maybe 30, but they're not going to look overweight because muscle
is
heavy and it's heavier than fat. So we need to take that into account as well. So it's an individual discussion and response. So we do have like the license criteria, but the consultation will kind of dig out whether, well, if you don't necessarily meet that, is there a justification here based on other factors? So like you said, ethnicity, family history, have you, what have you tried so far? What's your lifestyle aspects? If there's something we can do that would make sense for the medication to be utilized, that's great. But if it's, your BMI's approaching 20, you just want to look a bit thinner. Yeah. That's not the service we offer. Yeah. It's not, for me, the right thing to do for those patients.
Yeah, I agree. Yeah. So the journey would start off essentially with a consultation. Yeah. So if people wanted to book in with you, the process would be?
So they contact your staff at the clinic, and we have so far a monthly clinic on weekends, and then we'll be booked in for an hour consultation.
Which is a lot more than an online form.
Yeah, definitely. Yeah. I've got a very thorough process, and you've got opportunity then to ask any questions you might have. I do ask that we do it kind of as a video consultation, so we get to see each other and discuss it openly. And then following the end of that consultation, you've got an opportunity to think things through, ask me any questions, and then we would, if you're happy, proceed by having the clinic give you a call back and arrange the delivery of the medication. And then once that arrives, you then would contact me and we would go through again how we utilize it, the practicalities of it. And then from there on, we check in every 3 to 4 weeks and make sure that you're on track, that you're having no problems with the use of the medication, that we're at the right dose if we need to increase the dose gradually. And then we kind of start to then work on those things that you initially gave me as part of that consultation. So for some people, it's, they haven't really got that good awareness of how to select their meals, like what is good food selection, and they haven't really got any routine built on that. For others, it could be environmental factors. They're a working mum and they've got kids around the house and they need to, they keep a lot of treats in and they're susceptible to kind of having that themselves. For others, it could be, physical activity is a factor and we need to build on that. So trying to focus in on their habits and using that time to get the medication right, but also then start to build in on this.
So this is very unique, I think, because the Journey Back to Health program or service is not just here's some medication, inject yourself, off you go. It is coaching.
Yeah.
It is. I mean, it's a shame that the body coach has been taken, but you are a health coach, you're a lifestyle coach, you're a body coach. You support them in all aspects of their life.
Yeah.
And credit to you, because you have honestly done amazingly, and you are a superstar. You know that. You're so humble. You're not telling people the reality of how much you do and what you do, but I know. And it's amazing to have you at the clinic.
No, thanks.
I think I might have to book myself in.
You definitely don't.
Thank you so much for joining.
You're welcome.